Hello and welcome to Bite-Sized MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of MRCP within the last 5 years and want to help you do the same. We are not associated with any MRCP examination organisations, and the materials covered are by no means an exhaustive list of what can come up in your exam, or indeed medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic, which is psoriasis. So what is psoriasis? This is a cutaneous inflammatory disease due to increased turnover of the epidermal layer. Males and females are equally affected. There is a bimodal peak incidence of people in their early 20s and late 50s being affected by psoriasis. Prevalence is approximately 3%. Psoriasis is a T-cell mediated disease. Genetic and environmental factors are important in its pathogenesis. There is a polygenic inheritance pattern, and CD4 lymphocyte predominance is characteristic, particularly in the early stages. Psoriasis is characterized by well-defined multiple symmetrical scaly plaques. They tend to affect the extensor surfaces, and there is a sign known as Auspitz sign where there is bleeding on removal of the scales. Nail changes can also be a feature in these patients, including pitting, onycholysis, subungual hyperkeratosis. Onycholysis is the separation of the nail from the bed. And here we can see a picture of someone with psoriatic plaques over the extensor surfaces of their arms. History and clinical examination is key when assessing patients with suspected psoriasis. A skin biopsy may be performed, which would show epidermal thickening, dilated dermal capillaries, and a mixed inflammatory cell infiltrate. Treatment of psoriasis involves firstly topical therapies, which include vitamin D analogues, emollients, steroids, and tar. Phototherapy may be needed, and this is with UVB or psorellins with UVA or PUVA. In more advanced cases, systemic therapies may be required, and these include retinoids, methotrexate, cyclosporin, and hydroxyurea. Biologics, which may be used in the treatment of psoriasis, including infliximab and etanercept, which are anti-TNF inhibitors. And to find out more about these, you can refer to the drugs section of our rheumatology series. So let's try a question. A 20-year-old male presents with a 4 months history of bilateral scaly plaque lesions on the extensor surface of his elbows. The IMT2 doctor suspects a diagnosis of psoriasis and refers the patient for biopsy. Which of the following is not a characteristic finding in this case, assuming the diagnosis is correct? So our options are epidermal thickening, dilated dermal capillaries, mixed inflammatory cell infiltrate, CD8 lymphocyte predominance, and CD4 lymphocyte predominance. So you will remember in the investigation section that we discussed that the first 3 of those would be present on a biopsy in someone with psoriasis. CD4 lymphocyte predominance is also a feature, particularly in early stages. So the correct answer here is CD8 lymphocyte predominance as a feature which would not be present on biopsy from a person with psoriasis. Thank you for listening to this episode of Bite-Sized MRCP. If you like what you've heard today, give us a thumbs up and hit the like and subscribe button below to make sure you don't miss our next episode. Let us know in the comments which topics you would like to hear in future. See you in our next episode.